Thank you, Sajid, for those kind words of introduction. So in the next 25 to 30 minutes or so, myself and Chandrika will discuss about the place of traditional metformin among its novel competitors, whether we should prescribe with the evidence or with clinical experience. So outline of the lecture, first a few slides about the discovery of metformin, then we will discuss about the pharmacokinetics and mechanism of action, then what are the non-hypoglycemic benefits, especially in the field of cancer and cognitive dysfunction, and metformin-associated side effects, mainly GI intolerance and lactic acidosis. Then Chandrika will discuss about the therapeutic benefits of metformin, use of metformin in special groups, and repurposing of metformin. Regarding the discovery of metformin in European folk medicine, extracts of plant called French lilac, the botanical name is Gallica officinalis, were used to treat sweet urine. So scientists did some research on this and found out the active ingredient which caused hyperglycemia was either galegin or guanidine. However, it was too toxic and less effective in human use. So in 1922, almost the year of insulin, probably 1 year later, metformin, the chemical compound dimethyl biguanide, was synthesized, and it showed blood sugar reduction in rabbits. However, the first biguanide to be used in type 2 diabetic patients was syntheline, but in 1940s it was withdrawn due to liver toxicity. In 1950s, metformin in the name of flumamine was used to treat influenza. So a Philippine physician called Eusebio Garcia observed blood sugar reduction without significant toxicity when it was given to influenza patients. So with this background, in 1957, Gene Stern was the first physician to use metformin in type 2 diabetic patients. However, metformin went under the carpet because penformin was the preferred drug up to 1970s. And penformin was withdrawn due to increased risk of lactic acidosis. So then thereafter, metformin came into the market. Although it was in BNF since 1958, FDA approval was granted in 1994, and in 1998, UK PDS proved the effectiveness of metformin in clinical trials. Regarding the pharmacokinetics of metformin, oral bioavailability is about 60 to 70%, and absorption mainly occurs in small intestine. Metformin's plasma binding is negligible, and high metformin concentrations are observed in liver, intestine, kidney, and to some extent in brown adipose tissue. Metformin is not metabolized and excreted unchanged in the urine, so there are no active metabolites of metformin. So mechanism of action mainly occurs in 4 main tissues: liver, intestine, skeletal muscle, and adipose tissue. So if you think about the liver, metformin enters the cell through organic cation transporter, which is a member of soluble carrier 22 family, and it inhibits the mitochondrial respiratory chain. So here the hallmark is the activation of AMPK pathway, which leads to improved insulin receptor function, improved glucose transport into the cells, and reduction in fatty acid synthesis in hepatocytes and also in adipose tissue and skeletal muscle also. Not only that, AMPK activation leads to reduction in hepatic gluconeogenesis, another major mechanism of action, and also it inhibits the glucagon uptake into the cells, and thereby also it reduces hepatic gluconeogenesis. Another major site of action is intestine, where it has different mechanisms of action. Firstly, it increases the glucose utilization into the enterocytes, as demonstrated by FDG PET scans. And then it increases anaerobic glucose utilization and increases the lactic acid production in the intestine by about 10%. Not only that, it increases the GLP-1 secretion by L cells. So another important mechanism of action. Also, it alters the bile acid pool, and mainly it increases the bile acids in the small intestine lumen, and that's also an important mechanism of action in reduction in blood sugar. And also, even before metformin gets absorbed, there's activation of gut, brain, liver axis, and that has an effect on reduction in hepatic gluconeogenesis. Another very interesting area is that metformin's alteration of gut microbiome. Because we all know gut microbial dysbiosis is associated with obesity and type 2 diabetes. So what is this dysbiosis? It's the reduction in butyrate-producing bacteria and increased in opportunistic pathogens. So metformin increased the gut population of Akkermansia and Escherichia species, and there the effect is that it activates the endocannabinoid system and also reduces inflammation, and it prompts a thick mucosal barrier. So all these actions contribute for the glycemic control. There are some novel concepts also, especially in brown adipose tissue. This is very recent review article in Nature Reviews in 2023. So it's an important action because metformin increased the chemicals leading to brown adipocyte proliferation and differentiation. So this is another interesting area. And also not only only in mitochondria, there's action on lysosomes also, because cryo-electron microscopy reveal binding of metformin to lysosome protein subunits and activation of AMPK pathway, although the exact mechanism is not shown, but this is another interesting area. Also, metformin has an anti-inflammatory effect, and metformin might reduce, because these are might, because still no convincing evidence on humans, but might reduce meta-inflammation, that is low-grade inflammation associated with cardiometabolic disease, and also which is called inflammaging, that is low-grade inflammation associated with aging. So overall, metformin has different mechanisms of action in intestine, liver, skeletal muscle, and adipose tissue, leading to insulin sensitivity, reduction in hepatic gluconeogenesis, and net effect of reduction in hyperglycemia. Next, we'll move on to the diabetes, cancer, and metformin. As we all know, diabetic patients are more prone to develop cancers, especially liver, endometrium, pancreas. And only cancer with a reduced incidence in diabetic patients is prostate, possibly due to reduced testosterone levels seen in diabetic patients. So the next question is whether metformin has a favorable effect on cancer incidence and mortality. This is one of the meta-analysis. There are several, and which account for bias like BMI. So it has shown there's relative risk reduction with regard to metformin use in cancer incidence and also cancer mortality if it's used in type 2 diabetic patients. So how this beneficial effect of metformin in cancer reduction? There are two methods, indirect and direct. Indirect, mainly it's the reduction of insulin and IGF, because by activation of AMPK pathway, it improves the insulin sensitivity. So circulating insulin and IGF-1 levels are reduced. So thereby, these are essential chemicals for tumor growth. So thereby, there might be an indirect effect. And also, there's direct inhibition of mitochondrial respiratory chain in neoplastic cell, and which leads to, through the mTOR pathway, there's a reduction in tumor growth. These are possible mechanisms. Another area is type 2 diabetes, cognitive dysfunction, and metformin. So cognitive dysfunction, vascular dementia, and Alzheimer's disease are more common in type 2 diabetic patients. This Taiwan is a nationwide study which showed that patients with diabetes has a more risk of developing Alzheimer's disease. So next question is whether metformin has an effect on cognitive dysfunction. This is a Sydney Memory and Aging study, where these elderly patients were in 3 groups. One, non-diabetic patient, second group, diabetic patients on metformin, and third group, diabetic patients not on metformin. So their outcome measures were global cognition, executive function, and dementia-free survival. If you look at the worst outcome is with diabetic patients who are not on metformin, whereas diabetic patients who are on metformin has the same outcome as non-diabetic patients. So let's move on to the metformin-associated side effects, mainly GI intolerance, which is a common side effect seen in about 20% of patients, and about 5% of patients discontinue metformin because of this. So symptoms include nausea, vomiting, diarrhea, flatulence, and abdominal discomfort. So there are several mechanisms that metformin causes this GI intolerance. Firstly, metformin enters the enterocyte, another subunit protein is that SERT, which is responsible for serotonin secretion. So this is one mechanism. Then also metformin, as I mentioned earlier, it alters the bile acid pool and increase the bile acid levels in the small intestine lumen. So this is another mechanism which can cause GI disturbances. And also metformin alters the gut microbiome. So this is another mechanism. And also it increases the lactic acid production in the intestine. So that also might lead to gastric side effects. So this is a common side effect. And how do you manage GI intolerance? It's usually a gradual dose escalation of metformin. In a newly diagnosed patient, you should not start metformin 1 gram BD. It's better to start with a 500 BD and then gradual dose escalation, because as the time goes on, these side effects might be less. And also use of extended release formulation is important, because side effects, gastric side effects are less with extended release formulation. And also there's a promise of delayed release metformin, and use of gut microbiome modulators like probiotics might have some effect, beneficial effect in reducing GI intolerance. So last slide, metformin-associated lactic acidosis, which is extremely rare, and 0.06 per 100 patient years. Definition, acidosis with increased lactate in the setting of metformin use overdose in the concentration more than 5 milligrams per liter. And usually this occurs in the presence of other precipitating factors. So if you look at here, that if patient has circulatory failure or respiratory insufficiency, there's tissue hypoxia, which leads to anaerobic glycolysis and production of lactates. The only way of lactase clearance is by hepatic gluconeogenesis. So if there's renal insufficiency, then there's a metformin accumulation which inhibit hepatic gluconeogenesis and production, having lactic acidosis. So if you use metformin in acute settings in a rational way, this side effect can be definitely avoided. So if there are severe sepsis, hypoxia, acute renal failure, acute liver failure, metformin should be stopped. And if the patient having acute illness, it's better to reduce the metformin, but of course you can use, but reduce the dose, and then this lactic acidosis can be prevented. So next part of the lecture will be done by Chandrika.